Hi, Frank Diamond, the managing editor of Infection Control Today. With me today is Dr. Brent James, an internationally known expert on clinical quality and patient safety. Dr. James is a clinical professor at the Clinical Excellence Research Center, Department of Medicine, Stanford University School of Medicine. Dr. James was at one time the Chief Quality Officer and Executive Director of the Institute for Healthcare Delivery Research at Intermountain Healthcare. He knows about both the provider and the health plan side, in other words. Thanks for joining us today, Dr. James.
Thanks for having me, Frank. It's a delight to be with you again.
Since you're familiar with both the provider and insurer sides of healthcare, I wanted to ask you especially, what do you think is going to happen as far as the demand for non-COVID related services are concerned? I mean, we know that because of COVID, a lot of routine care, elective surgeries have been put off. So what's going to happen with that, do you think? You have any ideas?
Well, a couple of ideas, Frank. First, I serve on a number of national health policy groups, and we've actually been calling in real experts to discuss exactly these topics, what's happening out there on a broad scale. In that framework, the next thing to be said, it differs from community to community. So among those likely to be listening to this video, one experience may not reflect all experiences across the entire board. On the other hand, there are some markers that will help people see. Here's the first big one. It turns out that primary care and standalone specialty care has taken a real hit with COVID. Visit rates have dropped dramatically. It's not just the physician practices, small hospitals have taken a real hit too. So here's my first prediction. You've all seen in your communities the rate of consolidation of smaller practices, independent practices, joining larger systems has been happening. It's accelerating. The reason is that those practices and those hospitals have no choice. A number of them face going out of business, even with the loans that the government's giving today. It's going to be a shift. On the other hand, it's really not a new thing. It's an acceleration of an old thing. Some of the communities of your readers are going to be so far down this road, it'll make very little difference. For others, it could really pick up the pace.
Now, I wonder, with that kind of consolidation, are there what they call redundancies? I guess is a European phrase. And will there be layoffs of healthcare workers because of that?
Potentially, I think when you consolidate services, especially at the administrative level, that could always happen. Also, to a lesser degree at a specialty level. Now there will be some compensating factors, but you're right in thinking in those directions. That kind of large systemness, at one level it protects people, but at another level it only protects people who are part of the system. You see what I mean?
Right.
And it's going to concentrate.
Has there anybody come up with any ideas on what to do about this that resonate with you particularly?
I don't know if it's something that we do about it. It's something that's just going to happen. But you can tell in your own community how fast. Now, there's a second element behind it. There has been a fairly remarkable slowdown in elective services. Many hospitals, of course, have taken a real hit by losing those services. Frankly, in a few communities, COVID has consumed the resources of the health system. In the vast majority of communities, that wasn't true. It's partly based on fear among patients. People who should have been coming in aren't. Well, as you would expect, as it normalizes a bit, as people get more experience, the fear is going away, and those rates are starting to come back up. Now, the other problem is of course, that COVID and the shutdown have been associated with a major economic downturn. Here would be my advice to your readers. It will be about like 2008. We've been through major economic downturns before. You've lived through them, I've lived through them, we know what happens. In the long haul, it will be mostly like that. We know how to make our way through them. Again, it differs from community to community, but I think that if you think of it that way, think of it as a major economic downturn. Was it a bit anomalous? Sure. The reason is it just cut off cold with COVID. Right. But now most places are opening back up. There's still a bit of fear of people being afraid to come back and put themselves, as they see it, at risk in a healthcare delivery environment. I think that'll normalize pretty quickly. In fact, that's one of our problems right now, is maybe it's normalizing too quickly, especially among younger patients. They're not obeying the social distancing rules and the masking rules that would really help us out moving forward. But we know how to manage that. So I think that's the second thing right there.
Right.
Treat it as a major economic downturn. We've lived through those before, and we kind of know how they behave in our communities.
Now, my core readership comprises infection preventionists, also environmental services teams at hospitals, procurement teams at hospitals, supply side teams at hospitals, the people who are supposed to keep the supplies flowing. Will this impact, I guess specifically infection preventionists, a consolidation? What I'm hearing is that infection preventionists will be much in demand, not only in the hospital setting, but outside the hospital setting. Are you hearing from your business associates, people that you know in industry, that they're worried about how to keep their employees safe? And are they trying to perhaps lean on some expertise about infection prevention for that?
That's the third area I really wanted to talk to you about, Frank. I think that most infection control specialists, they have training that others do not have. Now, I'm a biostatistician, and as part of that, I'm trained in epidemiology. Right. Gives you some background. Let's just say I've been pulling out of my closet and spinning up to full speed basic infection control principles at a population level. It means a certain amount of Bayesian analysis, frankly. I need to resurrect sensitivity, specificity, the idea of a positive predictive value. I need to be able to share those with people. I see that happening at several levels. The first, of course, is just how do you control the spread of this disease, this specific disease, in the general population. I realize that many of us don't have our hands directly on those controls, but holy cow, I get hit on that every day. I bet that your readers do too on a regular basis because they have that specialized expertise.
Right.
The second thing, I've been amazed at how many care delivery groups, those physicians and nurses, they want guidelines. And they're a little confused about where to find the right guidelines, you see. There's a third area of it. Where is it going next? Looking forward. Well, it means that I've had to spin myself up. I keep fairly careful track of that literature. I find trusted sources. Oh, there's so much information all over the board on the internet from various news agencies, and so much of it is just frankly wrong, just bad. And what people are really looking for is a trusted voice. Even if you're not in direct control of the response to the system, people need your voice. But it means a certain amount of preparation along the way so that you're able to speak authoritatively and help people see a path through the thicket. Now, this isn't going to be the last one. COVID's just the current one. Right. It's a wonderful opportunity. There are so many other common infectious diseases that take a major toll every year. Maybe this is an opportunity to expand the good that we can do in a community at this time, given that people are finally listening a bit. I hear a lot of people saying that we really need to expand public health. What do they mean? Seems to me that we'd have a large voice in defining not just their future, but our future as those conversations take place in our communities. You see the idea? And then expand that even further.
Do you have an idea of what direction you would like to see public health go in?
I think that we knew in the past how to handle a major epidemic. It's very clear that because the time between was so long, we dropped the ball. There's no question. Now you have to understand, here in Utah, I have a former secretary of HHS. We spend a little time together from time to time, Mike Leavitt. Mm-hmm. He was there during SARS-1. And hearing Secretary Leavitt talk about what we learned with SARS-1, and then how, frankly, the Bush administration was on top of it. The Obama administration actually lowballed it. They took money out of it to support the ACA, the insurance expansion program. I thought that was a major policy mistake at the time. Turns out it was. Trump administration, of course, did not follow through and pull it back. And then we find ourselves a day late and a dollar short when the real crisis hits. So here's an opportunity to lay some foundation for the next one. We know how, but it takes leadership. And it's not just at a national level, it's down at your local level. Who's the voice that's going to help people understand that and move it forward in your community?
I would think possibly that infection preventionists will be reached out to. I guess also the hospital systems that you're talking about, you know, they are having their troubles. What about the insurers? How are they doing these days?
Oh. You know, it's they're standing on the sidelines a little bit. They have pluses and minuses. Their payments for COVID patients are up, but frankly, for insurance, general use of services are down so much that most of them are doing quite well financially. You see, so it's a bit of a mixed bag for them, but most of them on net, this has been a little bit of a financial windfall for them. I don't see them, maybe this is just my bias as a physician. I've never seen insurance companies really leading in this side. Maybe if they had a specialist within their ranks who could help them, who could generate or set that vision, but it's not their natural sweet spot typically. It's not how they typically think about their role. You see what I mean?
Yeah. How do they typically think about their role?
They think about it as supplying funding for healthcare and making sure that only necessary services are provided. They do a series of important functions. One's transaction processing, claims processing, surprisingly difficult. They do actuarial risk analysis to figure out how to price. They do network formation. There's a series of things that they do. The thing they don't do is deliver care.
Have you seen any country handle this right? I mean, I know you're keeping an eye not only what's going on in the United States, but you traveled the world and you've seen other healthcare systems. Anybody stick out in your mind as having the best approach?
There's a clear winner, to my mind, in the world. Well, not just mine. A number of our colleagues who watch these things too. Taiwan. Taiwan's done it right. They're a wonderful example of doing it right. South Korea was doing well. They got surprised. Singapore was doing surprisingly well. They left a hole in their defenses in their immigrant worker population in large dormitories and high rate of spread. Outside of that, they're a pretty program. There are countries like New Zealand that have done very, very well, but you have to remember they're an island in the ocean and they can close their borders. So they're kind of a special case. But Taiwan, a short distance from China, massive amount of travel, early on exposure, they learned from SARS-1. They were ready. They were ready with testing. They were ready with contact tracing. They've had less than 200 deaths in a population of well, something like, what is it? I'll get this wrong, 29 million people. But it's dramatically different from the experience of the rest of the world. So that's the one to study right there. They had some special factors in their culture. Wearing of masks was already really common. And as it turns out, SARS-2, COVID-19 is mostly spread through respiratory droplets. It's an upper respiratory infection, mostly through respiratory droplets is the main route. And so masks are effective. Of course, most masks, the way people mostly wear them, it's not effective in protecting yourself, it's just effective in protecting others. But that was part of their society. People before this happened routinely wore masks, so it was an easy step. Their contact tracing, let's just say they may not have quite the sensitivity to human rights that we have to privacy, but through cell phones and other mechanisms, through carefully integrated travel tracking of people who traveled in and out of the country, they did a great job of identifying and isolating potential vectors, cases that could spread it more broadly. But they're the one to study.
Let's circle back to what you said about hospital systems and how they're hurting these days. Are we going to find a situation, or has it actually already developed, where now that we really need more healthcare workers are going to start getting laid off?
So people will get laid off, first of all, to answer your question, but we need to be more precise than that. It's what kind of healthcare workers will get laid off. You said hospitals, and hospital services, I think they're going to mostly come back. Mm-hmm. So people associated with hospital services, it'll take a while for it to swing back. Currently, most hospitals are reopening their doors. They have a backlog. We call it elective, but it's really hard to draw a hard black line between essential and non-essential surgical services. Maybe we can delay, but that doesn't mean they're not essential. So they have a bit of a backlog and they've been working it off. So those services are coming back nicely. We need to wait until the population at need, also sometimes the population at risk, particularly the elderly, feel confident coming back into a healthcare setting. So part of the problem is just fear in the patient population.
Right.
But I predict over time, that's probably going to ameliorate. It typically does. And as that happens, we'll actually be working off a bit of a backlog for a while, but it'll come back up over time. Again, remember though, anytime we've had a major economic downturn, there's a drop in demand for healthcare services.
Right.
2008 was a pretty strong one. That one is a good experience. That's close enough in our recent history that most of us remember it. And we know what it was like. We've seen it. Well, here it comes again. And it's probably a pretty good model. The anomaly is, of course, with COVID, is it shut down cold. That was a little bit different, but I think that's a temporary phenomenon that's now starting to sweep back up. But the economic downturn, that's going to be with us for a while.
I'm guessing that you might not want to answer this question because you might be betraying somebody's confidence, but I'm fascinated to find out what former Secretary Leavitt had to say about all this.
He basically said what I just said, and he published it. By the way, it was testimony to the Lamar Alexander's Health, Education, Labor, and Pensions Committee.
Okay.
When you get him and his staff, you know, it wasn't just Governor Leavitt, it was his staff as well. Former governor of Utah, is why I say governor, it's his preferred term. They have strong opinions about it, but it had to do with careful central coordination and planning. By this point, we know that the initial modeling was off, so it was a wiser approach to how we modeled. It was having the necessary supplies. It was a clear, consistent message down to the states and to the people of the United States about what's high risk, what's not high risk. You don't want to trust those kinds of things to the news media. The news media is not a reliable source of information without careful expertise and control.
Right.
And then, of course, the supplies, a properly coordinated response. But of course, Mike Leavitt would have started this probably in November, December of last year.
Really? Okay.
Oh, yeah. That's when we were first getting a signal.
Yeah.
That something might be going on.
As far back as November, because I know the first cases.
That's the first cases that hit the news media.
Yeah. Okay.
Yeah. So people in Taiwan say that they were detecting something going on in China back in late November.
What surprised you most about this whole thing? Is there one thing? I guess it's all pretty surprising to all of us, but is there something that sticks out in your mind?
You know, I don't know if surprise is the right term, Frank. I'm an old guy now. I'm 70. I'm kind of a curmudgeon. I'm disappointed.
70, doctor.
Well, there you go. Things that well, not just me, any trained epidemiologist should see as obvious. You know, as a statistician, we call them proportional hazards models. It means there's not just one risk. There's this human tendency, it's probably evolutionarily built into us, that we focus on the one big threat, the saber-toothed tiger that's about to eat us, right?
Right.
Well, COVID is kind of a slow tiger that eats us a little bit at a time. But the fact is that even as you focus on that threat, you shouldn't lose track of the other threats. And that's my biggest disappointment right there, is that people that should have known better focus just on this one. I thought our national leadership should have been a little bit broader in their application. There are real health risks associated with this that aren't directly from the SARS-CoV-2 virus. You see, I wish that we had been broader in our understanding. We should have been, we know that. That we should have been paying more broad attention. The way I teach it to my students, pardon me?
Can you give me some examples? You mentioned some threads that weren't.
Oh, here's one that's topical for me because I get involved in health policy. We had at a policy level nationally, we were talking an awful lot about social determinants of health.
Right.
Social networks, access to care, access to safe housing, food, water, a whole series of things like that. We knew that they were associated with a major significant health risk that associated with mortality rates, you see, and we were trying to call attention to it. Well, it turns out that damage to social determinants of health is associated with a major economic downturn. you
Right.
see.
Right.
So SARS-2 hits the streets. We shut down our economy. People lose jobs. We try to backfill with government programs, but a little bit unsuccessfully. We haven't seen the end of it yet. But we weren't considering the health consequences of the economic downturn. It's not about the money, at least not directly. It's about the lives.
Right.
And you're balancing these two, and how do you balance them back and forth? It's that kind of a conversation. Now, to really have that conversation takes some real training and expertise.
Yeah.
But then how do we tap the kind of training and expertise, well, that the members of your group so ably brings to the table? How do we make that available to people? It reduces the fear levels. It gives people a clear path forward to a greater degree. They know what's safe. They know what's dangerous. They don't see just the one risk. They see the other risks too, so they can kind of balance them out. And it means we respond more intelligently. We respond more wisely than we have.
And the social determinants of health have come into play in this epidemic too.
Oh, heavens, yes. And we're seeing it especially in underserved populations. They have higher risk factors to begin with in terms of comorbid diseases, obesity, other risk factors directly associated with social determinants of health. They have poor access to the health system. So we see disproportionate mortality rates in African-American communities, for example.
Mm.
You see, if you look at the way that those diseases play out, that was completely predictable.
Right.
So it's that level of thoughtful examination.
Dr. Brent James, thank you so much. Is there anything you want to add before we say goodbye?
I'll give you one thing.
Okay.
This comes from some of the national groups in which I participate. I'm really hoping, both fingers crossed, it'd take a minor miracle. What I'm hearing is to really have an effective vaccine could take 2, 3, or 4 years.
Ooh.
The earliest we'd probably have it is the end of 2021. Now, it's not just developing a vaccine that actually works and testing it and showing that it works, understanding its comorbid secondary effects, right?
Mm.
The complications associated with it. It's getting it available at scale. It's getting a good distribution network, picking the populations that are at highest risk. There'll be all sorts of hype around this coming up. The best expertise that I've been able to find suggests that probably it's 2, 3 years out. Now, we could get lucky. Let's hope for it, right? We'll hope.
Yes, sure.
What will happen short term is far better treatment. We already have that new trial on dexamethasone, a cheap, readily available steroid that we've used forever that seems to stop cytokine storm and give better outcomes for people with the most serious disease. What I'm hearing is that probably by November, December timeframe, somewhere in that range, monoclonal antibodies will be available at scale. That could be a game changer in terms of treatment of the disease. Now, the reason I mention this, I believe that your constituency, infectious disease doctors, kind of know about this stuff. They know how to track it. Again, it's supplying that expert voice by tracking those things so that people have a realistic expectation about what comes next and how they need to behave.
Mm.
This is within our reach, but it does take some specialized training, a little bit of wisdom along the way. Where do we turn for wisdom? Where do we turn for knowledge? Some groups, it seems to me, are head and shoulders above the rest. So guys, get out there, get to work.
But Dr. Brent James, thank you so much for joining us here at Infection Control today.
Well, thank you. And I'm delighted to have a chance to talk to you again, Frank. And I look forward to the successes you're going to put on the board. So great to be with you.